All right, thank you for the invitation to speak to you today, and thank you for attending. And it's difficult to follow Dr. Galati's talk, but I'll try to make it entertaining. So I was tasked with talking about urban environment, and I was only given 20 minutes to do it. So let's try to do that. I am part of the faculty at Houston Methodist. I'm also the medical director for the Center of Health and Nature within Houston, which focuses on the intersection between environments, urban design, and health. So the objectives of my talk will talk about summarizing the clinical and epidemiologic studies that really linked neighborhood characteristics with cardiometabolic risks. We'll touch upon the potential mechanisms that link these two things and outline some mitigation strategies to reduce exposures. So if you look at cardiometabolic disease or cardiovascular disease in this case, and type 2 diabetes follows suit, look at the Global Burden of Disease study, which is a study that comes out every year that talks about models, basically the modifiable and non-modifiable risk factors. You see that things make sense when you talk about high blood pressure, tobacco, dietary risks. But one of the most important things that is really almost never talked about in clinic, never talks about in medical conferences is air pollution. And air pollution as a prototype for environmental exposures, environmental risks, comes up to be one of the major causes of premature mortality in the world. So it's responsible, just air pollution itself, it's responsible for approximately 7 million deaths annually globally. And that exceeds everything that we are taught in the books combined. It exceeds combination of tuberculosis, AIDS, influenza mortality, and malnutrition, alcohol use, and everything related to that. And think about it. I mean, you're exposed to environmental exposures, whether you like it or not. You're breathing the air every second. It's not as smoke where it ends in 1 minute and you're not exposed to it until the next cigarette. But this is something that you're exposed to from the time you're in utero until the moment you die. So this is something that is a major issue, although the components of air pollution may be different in Western world versus Eastern world and so on and so forth. There is a huge impact on cardiometabolic risk. So every few years, the American Heart Association comes up with Life Essentials, or in this case, Life Essential 8, which is really, it used to be Life Simple 7, which are really things that are you have to follow to improve your risk and improve your health in general, cardiometabolic health. And most recently, this is Life Essential 8, where they incorporated this bottom part, which is really the social determinants of health, talking about individual, interpersonal, organizational kind of aspects. But I would go a step further and then introduce this concept of the exposome. The exposome is really comes from two different words, exposure and omics, where we like in science. And think about the exposome as everything that you're exposed to from the moment you're conceived till the moment you die. And this can be conceptualized in 3 different components. The personal exposome, where we're talking about diet, exercise, work, toxic chemicals that was talked about earlier, sleep, social interactions, but also climate, the external exposome, which includes climate, green space, what is around you, even noise, pollution, traffic pollution. And I'll try to touch upon some of these during my talk today. But these 2 components of the exposome, the external and the personal, they do interact with biologic responses. And we heard earlier about the genetic components and the genetic determinants of health, and really racial, ethnic, other things that may be related to how we respond to some of these exposures and how we study them as well. So the microbiome, the metabolomics, and inflammation, gene expression, and so on and so forth. So this is, I would urge you to think about reading this paper that came out in Circulation a couple of weeks ago, where we really try to summarize some of the components of the exposome as they relate to urban health and cardiometabolic health. So urban design, urban exposures, and cardiometabolic health. And the focus on urban is really because the world is urbanizing. If you look at the urban population is increasing dramatically. People are either moving from rural areas to urban areas, or the cities are growing, and there's urban sprawl. And Houston is a perfect example of this, where rural areas a few years ago are becoming more urban. But you can think about on the left side, you see the different aspects or different angles of cardiometabolic disease. And on the right side, you see some of the angles of your neighborhood and the exposures and access to housing, transportation, waste, energy, and water supply, which are really big issues that we need to tackle. So I want to convince you that really where you live matters. We've heard earlier about zip codes, and a lot of us think, at least clinicians, think that, okay, you live in a poor neighborhood, that's non-modifiable, and it's really not the neighborhood itself that is impacting you, but rather it's a matter of who you are, where you live in that neighborhood. But there are actually good quality studies that showed otherwise. So this is a really nice study from the VA. The VA, the nice thing about the Veteran Affairs system is that they incorporated electronic health records a long, long time ago. So now we have the capability of looking at longitudinally at individuals and where they moved from one individual, from one area to another area. So this is a clever experiment that was published in JAMA a few years ago, where they followed people and they asked a simple question. If you move from an area that has low control of blood pressure to an area that has high control of blood pressure, do you adapt to the area or do you remain, from where you came from? And all of these figures here, they looked at uncontrolled blood pressure, uncontrolled diabetes, obesity, and depression. And all of them, you basically adapt to the new neighborhood, and this is all within the United States. You adapt to the new neighborhood that you are moving into. So if you move to a neighborhood that has better control of blood pressure, your blood pressure improves. If you move to an area that has better control of diabetes, your diabetes improves. So this is a one step closer to causality, but I think that probably the best evidence that we have thus far is this really clever, I think it's probably one of the most important trials that we have and most well-designed trials that we have in population health, where the Department of Housing and Urban Development designed this cluster randomized trial where they took women and children who live in high poverty neighborhoods. And they randomized them to 3 groups. One is we do nothing, we just follow you up for looking at your BMI and A1C a few years down the road. The group number 1, I will give you a housing voucher and you do whatever you need to do with it. And number 3, I will only give you a housing voucher if you move from your neighborhood with high poverty to a high income neighborhood. And lo and behold, what you can see is they followed these patients. There's about 4,500 women and children, and they followed them up to about 10 years. And you can see, I'm comparing here only the low poverty voucher, where they kind of forced people to move out of their neighborhood to get the voucher versus control. And you can see 5 and 10 years down the road, there is a significant reduction in the percentage of people who are obese. This is women and children, both with regular obesity and severe obesity, and also A1C by 6.5 and above, which is definition of diabetes. So you see that there is we have randomized evidence to suggest that if people move from one neighborhood to another, and they adapt to the neighborhood that they move into, and they can actually improve their health outcomes. So I'll talk a little bit about air pollution. And the reason why I focus on air pollution for a few slides is because it's the most studied environmental risk factor. We have evidence all the way from population studies to epidemiologic studies to interventional exposure studies, which are no longer ethical, to interventional trials where we reduce in air filtration and so on and so forth, to mouse studies that are well controlled and cellular mechanisms. So if you look at the plethora of data that we have right now, we plot these dose response curves. And on the left side, you see that on the x-axis, you have the particulate matter, which is the solid component of environmental pollution or air pollution. Excuse me. And you see the concentrations. And in the US, we're lucky to live up on the lower side of things. We're about 10. We're still above what is accepted as the threshold of 9 by the EPA and 5 by the WHO, but we're still on the lower side. But it's not uncommon in areas where, in Pakistan, for example, in Bangladesh, in India, where exposures or PM concentrations can be on average about 100 microgram per meter cube. And on some days where you have really polluted areas, it can exceed 500. So it's not uncommon for these days to happen, and that's why people start to wear some masks and things like that. But you can see the relationship is actually curvilinear on the left side. You see on the y-axis, we have relative risk of incident cardiovascular disease, includes stroke and heart attacks and cardiovascular mortality. And on the x-axis, we see the PM concentration. And there is some sort of a plateau effect. which makes it very, very critical for the levels, on the low levels, because you can actually, even by reducing a tiny amount of air pollution on the x-axis, you can derive a bigger benefit in areas where you're on the lower spectrum of things. On the right side, you see a similar study, but this looks at diabetes, so incident diabetes, and we oftentimes plot secondhand smoking as part of the curve because it mimics the same exposures and it extends some of these exposures to higher levels, but you see the same story on incident diabetes with household air pollution and outdoor air pollution. This is a busy slide, and I'm not going to go through it, but the idea here is to show you that these mechanisms have been worked out in humans and in mice. We have causality, and now we know that air pollution is causal for diabetes and it's causal for cardiovascular disease, and we're expanding our knowledge a little bit with respect to kidney disease. But you see there is basically, as these particles get inhaled, they do have direct effect on the brain, they do have inflammatory response in the lungs, and they lead to changes in the microbiome that have significant impact at the endothelial level and intracellular mechanisms for inflammasome activation. And it affects actually multiple organs. We've done some experiments in mice where we exposed mice to levels slightly above what we get in the United States, and we see diffuse epigenetic changes across multiple organs that mimic high-fat diet in well-controlled studies. So this is something that can have a significant impact even at exposure levels that are low. So just to conceptualize this and to leave you with this figure here about air pollution is we think about air pollution as initiating the mechanisms of air pollution causing cardiometabolic diseases. We have three main initiating mechanisms. We have oxidative stress that happens in the lung primarily. We have some biologic intermediates. These are interleukins primarily that start from the lung and kind of go to multiple organs. And we have some small ultrafine particles, including microplastics, that can translocate through the alveoli and the gut barrier to the blood that lead to areas in different organs. And we have effector mechanisms that include autonomic imbalance, endothelial dysfunction, inflammation, thrombotic pathways, all of which can contribute to cardiometabolic disease. So we left air pollution for a second, but I wanted to talk a little bit about noise, which is something that's also not talked about as much. There's significant amount of data on noise, including randomized trials of exposure to noise and removal of noise. And noise levels that we consider them unhealthy, these are exceeding 65 decibel, which are really passenger cars, telephone ringing, truck. But think about, for us clinicians, when we go to the ICU, for example, all this ringing and ringing and ringing in the ICU can, all of us experience some stress with it. And the impact of noise is really primarily through stress-induced factors, mechanisms that can really increase inflammation, oxidative stress, and we have animal and human studies that showed this. And on the right side, you can see the hazard ratio for incident ischemic heart disease increases significantly above 60 to 65, and same thing for stroke, and we have evidence to suggest that it does increase blood pressure and incident hypertension as well. We talked a little bit about food during some of the talks today, but you can see there's significant disparities with respect to cardiovascular mortality on the y-axis, on the left side. But you can actually explain a lot of this disparities or variation in cardiovascular disease or cardiometabolic disease just by looking at the food environment around you. And there are multiple metrics we used. In this study, we used food environment index, which is a combined metric of availability of food and food security close to you. And then you can see that both food environment index on the right side and income inequality are additive to each other to explain cardiovascular morbidity. Flipping slide here a little bit and thinking about temperature, and Houston definitely is a big, Texas specifically is definitely a big problem for temperature, but temperature is increasing across the globe owing to climate change and other things, but really the combination of getting more elderly individuals, aging populations, urbanizing populations, and increasing temperature is leading to an epidemic. We estimated approximately 1.2 million cardiovascular deaths related to non-optimal temperatures. A lot of these are related to heat, and we are in the process of investigating the impact of heat, temperature, humidity, and on top of that, power outages to understand what is really the added impact in the state of Texas. I'm not going to spend too much time on the mechanisms, but just realize that there are also some human and mice studies that have studied the impact of temperature, both cold and hot, and it leads to significant changes in your hypercoagulability, hemoconcentration, especially heat, and it causes stress on the heart, and especially true for patients who have pre-existing disease. And things to think about is diuretics, beta blockers, and aspirin. There has been studies that looked at these medications causing significant increases the susceptibility to heat impact. Now, built environment is something that has not been, we all think about built environment as something that can impact health and so on and so forth, but for the most part, the people who design cities, they don't think about health, and people who think about health, they don't think about city design and so on and so forth. So here we started to think about how can we quantify the built environment from a lens of health, and we asked a simple question. If we look at Google Street View images, Google satellite images, these are broadly available throughout the world, primarily in the United States, and we wanted to ask a question is there information in these images that can help us understand the health of the population? So in these two studies, we took these Google satellite images, Google Street View images. We took 7 urban cities in the United States, and we said, okay, we fed it through a novel AI model, and we said, okay, can we predict the prevalence of coronary heart disease, chronic kidney disease, and stroke? And on the right side of these 3 scatter plots, you can see that there is a linear relationship between what's predicted by the images. These are images only, no demographics, no risk factors. All we're looking at is prevalence of coronary disease and prevalence of chronic kidney disease. And we find is about 60 to 70% of what we find in terms of variation or geographic geospatial variation in cardiometabolic disease can be explained by just looking at these images. And not only that, this can be applied also to individuals. And on the bottom part of the slide, you can see Kaplan-Meier's. These are patients who are primary prevention patients, and we follow them up for incident major adverse cardiovascular events, and we see that the higher the risk that's predicted by these images can be predictive of cardiovascular disease. Not only that, this AI tool that we developed can also highlight in these images what is really what is contributing from these images to the risk. And we can see both high risk and low risk, and you can see just as an example, in the top part, and I don't know if I have mouse here. Yeah, in this top part, you can see that what is being predictive of lower coronary heart disease is this green space here, which kind of starts to make sense. So, this is all unbiased approaches that help us understand what is in the design of the environment, of the built environment around us that can help us understand cardiometabolic disease. 1 second here about microplastics. I mentioned it earlier. So microplastics and nanoplastics are increasingly being recognized as potentially contributing to cardiovascular disease. This is a recent study from the New England Journal of Medicine from colleagues in Italy that looked at the presence of microplastics. These are really, really tiny, small particles that are available in plastic bottles and things like that, that we find them in atheromas. We find them in plaques that are part of that can contribute to risk of heart disease and stroke. So more to come about this, but this is something that is really alarming because of the wide availability of plastics. And in this cohort, about 50% of the patients had detectable microplastics in their atheroma. So this is a conceptual framework thinking about the exposome. The exposome is from embryo throughout adulthood. And all of these things can be helpful or harmful. So we can think about the exposome, although it's always thought about as being bad, but really they can think about a healthy exposome. And how can we grow the healthy exposome as part of this? So things that can, the beneficial part of the exposome that can enhance stress resilience, enhance circadian adaptation, and enhance our immunoredox balance. and that can maybe counteract some of the harmful effect of the exposome. And some of these things include walkability. We've done this national study looking at how walkability is associated with cardiometabolic disease, and you can see the more walkable the neighborhood, after adjusting for various risk factors, the less likelihood for developing high blood pressure, cholesterol, obesity, diabetes, and coronary disease. And now there are novel geospatial methods that allow us to kind of integrate all of these factors together. So this is an analysis where we looked at premature cardiovascular mortality throughout the United States, and we showed that you can actually start to rank and look at the intersection between some of these things that can impact health and things that may not be very apparent to us in the clinic, including even broadband access or insufficient sleep or having access to exercise opportunities come up to be among the top contributing factors to cardiovascular mortality. I'm going to slip a couple of slides for the sake of time, but this is an important paper that came out in Lancet a few years ago that looked at obesity from the lens of systems dynamics, from the lens of micro, meso, and macro systems. And thinking about obesity is not something that we can just tackle by prescribing a medicine to patients, because it's bigger than that. And there are natural systems, there's governance, there is policies that are impacting neighborhoods. So there's a lot of feedback loops, and you can look at it from a global outcomes view, from a syndemic view, where they have syndemic of environmental exposures and obesity and cardiometabolic disease. There's a lot of feedback loops that may have unintended consequences by altering some parts of the environment, and so on and so forth. So I get always asked whenever I give talks like this is, why do I care? As a clinician, why do I care about the environment? And I'm trying to get it clearer and maybe closer to us, closer to home, is by presenting this example amongst many, but environmental exposures can actually interact with some of the medicines that we give to our patients. So in this example, what we did is we looked at the SPRINT trial, which was mentioned earlier by Dr. Ballantyne, where we looked at SPRINT trial was a large randomized trial of lowering blood pressure intensively versus regular lowering of blood pressure, and it showed that there was a reduction in cardiovascular disease. So just talking about precision medicine, this is an example where we took patients who participated in this trial, about 10,000 patients, and we looked at where they live, and we linked them with their environmental exposure. So we assigned air pollution levels to every patient, and we looked at if you are exposed to higher level of air pollution versus if you're exposed to lower level of air pollution, what is your outcome with respect to an intensive lowering and standard lowering of blood pressure? And we were surprised to see that not only the absolute risk reduction was higher if you're exposed to or you derive bigger benefit from an absolute terms, but you also derive a bigger benefit from a relative terms. So if you look at the on the right side, the intensive treatment lowered significantly compared with the standard treatment, as opposed to the still some lowering, but less intensive lowering on the left side. So environmental, and this is just an example, there is more to come. We're presenting a study in AHA looking at finerenone and its interaction with air pollution on cardiometabolic disease outcomes. But you can see that there is an opportunity for us to study environmental exposures within randomized clinical trials. The other thing that we could do as clinicians, there's actually significant amount of evidence. All of these are randomized trials that showed that air filtration, cheap air filters, approximately $20 to $50, can reduce air pollution significantly, but can also reduce blood pressure. And there is evidence to suggest that it can reduce insulin resistance, liver fat, and it can reduce obesity, improve sleep. So there is a significant benefit by reducing, and almost all of these studies are actually in the United States where the levels are very low. So we ought to look at this a little bit more closer and think about maybe dealing and talking with payers to maybe cover some of this in high risk areas. And there are things that we can do as personal mitigation. There are N95 and N99 masks that can help during exposures, wildfires, which we've had recently, especially in California, but we're having some fires here in Houston, which can impact our air quality. And one last thing here for 1 second is that we are complicit in the environmental harm. Cardiovascular disease specifically, cardiovascular care, but all healthcare is a significant global greenhouse gas emission source, and we ought to do better in terms of improving our sustainability. And this is a nice overview that we put together that looks at some of the potential ways for us cardiologists to reduce our environmental footprint. So the one last slide here, and talking about, we've been all cardio focused. We study the heart, specifically cardiologists. We've been thinking a little bit more outside, thinking about risk factors and physical activity and so on and so forth, similar to Life Essentials. And more recently, we started to think about residual thrombotic risk, residual lipidomic risk, residual inflammatory risk with trials. But we got to think about residual social risk and residual environmental risk when we talk about our patients. So in conclusion, hopefully I convinced you that neighborhoods and exposome factors can impact cardiovascular and cardiometabolic health. We understand some of the environmental impact, but we need to understand it more, especially to understand the residual risk and how to quantify it. There is emerging evidence to suggest that targeting the urban environment can reduce cardiometabolic disease, and we need policy interventions, urban planning. We need to sit together on the table, not work in silos to actually improve cardiometabolic health. From patient standpoint, we really need to reduce carbon footprint to protect the environment, but sometimes portable air cleaners and N95 masks for high-risk patients. Clinicians, we need to assess environmental hazards. The how and when needs to be explored further, and we need to advocate for environmental health. It's all of our jobs. And healthcare, we need to reduce waste and improve sustainability. And from a society standpoint, we need to invest in clean energy and public transportation. And for all of us, really, we need to recognize our responsibility towards the environment. Time to act is now.